Yeah, the oral SERDs in general as a class, and I think you would agree, and you and I have both used a lot of these, both on and off clinical trial in the early stage and the metastatic setting in clinic, are generally very well tolerated. I would argue in my own personal practice, and I'm curious to hear what your thoughts are, they do have the menopausal and the kind of joint muscular symptoms, but they're actually somewhat less intense than, for example, on aromatase inhibitors. The trade-off as a class, we'll talk about Camizestrant in a moment, but as a class, maybe slightly more low-grade GI toxicity, usually some nausea, reflux, maybe a little bit of diarrhea. But the rate of dose reduction or discontinuation was generally very low.
Very low.
And in my own personal experience, I've almost never had to dose reduce these agents. Some of these drugs do have a couple of unique, usually low-grade mild side effects. Camizestrant occasionally has photopsia, this sort of changes in light in the peripheral vision.
Flashes of light.
Yeah, flashes of light in the peripheral vision. I think it was about a 20-ish% rate on Serena 6.
But no change in visual acuity.
No change in visual acuity. No
it's reversible.
and no significant impact on function.
Right.
Pretty much all of it was low grade, and this seems to be maybe a unique side effect. Other agents in the class can cause, for example, low grade bradycardia, which we don't see as much of here with Camizestrant. And the other point I would make about the toxicity is, as we've looked at these drugs in doublet regimens, both Serena 6 and in other studies like Evera or Ember 3, we see they're highly combinable, and they don't really seem to add a lot of toxicity, for example, to a conventional CDK inhibitor or to an mTOR inhibitor like everolimus.